everyone, my name is Danielle Gatti-Palumbo. I'm a clinical pharmacist at Northwell Health Division of Rheumatology in Long Island, New York. And today we're doing a journal club. The title of the journal is A Review of the Safety and Efficacy of Deucravacitinib for Plaque Psoriasis, an Expert Consensus Panel. This was published by Milan Shaw and colleagues and published in Journal of Drugs in Dermatology as of February of 2025. So a little background is that tyrosine kinases are a part of the Janus kinase or JAK family. And tyrosine kinase 2, or TYK2 specifically, is responsible for mediating IL-23 signal transduction and then converts immature T cells into T helper type 17 cells, which then causes a release of IL-17 and causes the chronic inflammation that we do see with psoriasis. So essentially, it's similar to an IL-17 inhibitor. Deucravacitinib is a first-in-class oral selective allosteric TYK2 inhibitor. And by inhibiting this TYK2, it is more specific and also more selective in the downstream signaling, as well as a more narrower spectrum of cytokines that we see versus our JAK inhibitors, which are non-selective and often will affect other JAK pathways. Deucravacitinib is a tablet. It is dosed at 6 milligrams once a day. And currently in the package insert, they do list the most common side effects of it as being infection, as well as upper respiratory tract infections. A little less common are herpes simplex, mouth ulcers, folliculitis, and acne. Now, currently, deucravacitinib does not have any black box warnings that you do see with JAK inhibitors, but because of the relationship with JAK inhibitors, it does have some cautionary language that we see with our JAK inhibitors, such as the increase in CPK, LFTs, as well as triglycerides, and cardiac and thrombo events. However, based on clinical trials, this has not been shown with deucravacitinib, nor any laboratory abnormalities have been shown with deucravacitinib. So with that, this aim of this review was to provide some clinical recommendations on the safety and appropriate lab monitoring of deucravacitinib, as currently there's really no guidelines available. This was a study that was a panel of 10 experts in plaque psoriasis, and it was a literature review that found and reviewed about 101 articles, of which 14 were selected and presented to the panel as a roundtable sort of discussion. And together, they formulated 6 consensus statements regarding the risk factors associated with psoriasis and also recommendations on the appropriate monitoring of deucravacitinib. Now, each statement was also given a strength recommendation based on the SORT criteria, and the statements are as follows. So the first statement is that in a double-blind placebo-controlled study with deucravacitinib with apremilast as an active comparator, deucravacitinib displayed greater efficacy at week 16, and this continued to show improvement through weeks 24, as well as a maintained improvement during a 4-year open label extension. Statement 2 is that deucravacitinib has an excellent safety profile and is very well tolerated. Unlike apremilast, which has the side effects of headache and GI side effects, this was not seen with deucravacitinib. Statement 3 is that by targeting this TYK2 pathway, deucravacitinib is a selective and also has a more unique mechanism of action that, in contrast to non-selective JAK inhibitors, in the 4-year safety data of deucravacitinib, they did not see that increased risk of thromboembolism effects or cardiac or MACE events or serious infection or malignancy that we do have with the JAK inhibitors. Statement 4 is that no evidence to support that there's any abnormalities in the laboratory values of LFTs, CPK, triglycerides, or cholesterols in patients on deucravacitinib, and basically that the data with deucravacitinib does not demonstrate any need for baseline or ongoing laboratory monitoring. As such, with like our JAK inhibitors, we have the risk of anemia as well as leukopenia, so we may have to monitor them a little bit more closely. But this is not seen with deucravacitinib. So lastly, statement 6 is that because of the associated comorbidities that we do see in our patients with psoriasis, and this can include Crohn's disease, uveitis, cardiac events, metabolic syndrome, as well as being on other medications such as methotrexate, which in this case, methotrexate is actually not recommended to be given with deucravacitinib. The expert panel said because of these comorbidities, it is actually, they advocate for baseline evaluation of lipids, CBC, as well as BMPs. And also they stated that insurance companies may still require a TB as well as a viral hepatitis panel to be drawn prior to starting therapy. So of note, all of these recommendations or statements had a SORT level, a strength strength of A, except for the last one being a C. And they basically concluded that deucravacitinib is a safe and well-tolerated selective TYK2 inhibitor. These 6 consensus statements will aid clinicians during initiation and also ongoing monitoring of patients on deucravacitinib. In this case, it doesn't really require much monitoring. And that in clinical studies, there's no evidence of any abnormalities in laboratory parameters and therefore does not require much monitoring. And it is not known right now whether TYK2 inhibition may be associated with observed or potential adverse events that we do see with the JAK inhibitors. But because of the similarity, there is some language in the package insert of these potential risk factors. However, for our patients especially, deucravacitinib may be a great alternative, especially for patients that can't take JAK inhibitors because of the associated risk with cardiovascular or MACE events or increase in CPK, triglycerides, or LFTs that we do have with the JAK inhibitors. So great option for our patients, and we look forward to further using this in our patients. And for further information, please visit our wrap page and click Rheum content for more. Thank you.